So thank you for the opportunity. I feel like prostate always comes last, but maybe for a good reason. Great, just advance here. So I want to talk to you about screening for prostate cancer. Thank you. No disclosures. And so just by way of background, and I think we've gone over some of this, prostate cancer is the most commonly diagnosed non-cutaneous malignancy in men, accounting for over 180,000 diagnoses last year. It's also the second leading cause of cancer death behind lung. And there are certain well-established risk factors, including older age, African ancestry, a family history of prostate cancer, as well as inherited genetic contributions, mutations in BRCA1 and 2, and Lynch syndrome. Prostate cancer is also remarkably variable in its clinical presentation, ranging from an indolent tumor incapable of metastasis to very aggressive cancers which rapidly result in death. So what is responsible for the high incidence of prostate cancer? I think it's really the contribution of two factors. Number one, a high latent prevalence of the disease, as well as our efforts in early detection. So since the implementation of widespread PSA screening in the 1990s, there's been a doubling in the incidence of the disease. But at the same time, there's been a significant reduction in the risk of death from prostate cancer, as well as the occurrence of metastatic disease at presentation. At the same time, it's estimated that a quarter to almost a half of PSA-detected cancers would have never been diagnosed if we never looked for them. And therein lies the quandary. And I think that was sort of well encapsulated in the U.S. Preventive Service Task Force Grade D recommendation against routine screening that was issued in 2012 and sort of turned this conversation on its head. I think that point is also very well contextualized, looking at SEER data, looking at the incidence of metastatic disease at presentation following the implementation of widespread screening. A marked reduction was seen following PSA screening, interestingly more or less a flat line following mammography. Those declines in mortality have been seen across the board. However, African American patients still face a marked disparities in the risk of death from prostate cancer, over twofold those of any other race or ethnicity. So the big question is prostate cancer worth screening for? And by screening, I'm talking about PSA screening of asymptomatic men, as well as digital rectal examination. So I think we need to be quite careful how we weigh the relative harms and benefits, and that's really been the theme of our discussion tonight, and I'll take it a little further here. So what's the evidence in support of a benefit to mortality from prostate cancer screening? And I think this is probably some of the best data we have. This is the European Randomized Screening Trial. And this is really a remarkable study performed across multiple countries in Europe, over 182,000 patients who were randomized to screening at 4-year intervals with PSA. A biopsy threshold of 3 nanograms per milliliter was employed as a trigger for further investigation. And we start seeing the lines diverge pretty dramatically at 11 years and 13 years. And at 13-year follow-up recently published in Lancet in 2014, the number needed to invite to screening dropped to 781, the number needed to detect 27, and a relative risk reduction of 27%. But the story doesn't end there. I think the harms are well known in terms of overdiagnosis and overtreatment. Screening with PSA as a biomarker alone has a high false positive rate, nearly 75%, meaning 75% of patients who have an elevated PSA above 4 will have a negative biopsy. There are risks of having a biopsy. So the risk of infection or sepsis ranging from 1% to 4% nationally. Our rate at Yale is lower. Biopsies are uncomfortable, associated with anxiety as well. And then of course we have to return to the overdetection issue, finding low-grade cancers which are non-lethal. And treatment of patients is inherently overtreatment. These are cancers that will never cause death. Why does treatment matter? Because treatment is not benign. There's an established rate of urinary incontinence following surgery or radiation, rates of erectile dysfunction, as well as rates of bowel toxicity associated with radiotherapy. So in synthesizing recommendations at Yale, I think we're really trying to balance multiple factors. First and foremost, the strength of the evidence, guideline support for major bodies, including the task force, NCCN, the American Urological Association, as well as the needs that reflect our community as well. So what are our recommendations? So First and foremost, the statement that the harms and benefits of prostate cancer screening are not definitively established. Essentially a statement that we're not entirely sure how that ratio plays out. But we do endorse shared decision-making between patients and healthcare providers, and that's endorsed by virtually all guidelining bodies that support prostate cancer screening. The considerations that should be employed include age, race, ethnicity, health status, and a family history of prostate cancer. So for men at average risk, men in the absence of those risk factors, men under the age of 40 should not be screened. For men in their 40s, we believe there should be an opportunity to have a baseline PSA drawn to help inform discussion of further screening. There's a very large body of evidence supporting the role of a baseline PSA in predicting the risk of lethal prostate cancer over a man's lifetime. At age 55, a shared decision-making process can be undertaken, and for men electing to be screened, we are advocating biennial PSA screening that may be adequate based on that initial value. Screening should stop at age 70. For patients 70 and older, an individualized approach can take into consideration the health and the patient's life expectancy, and this is endorsed by the American Urologic Association. What about men at higher risk, those high-risk groups we spoke about, and identifying here as African-American men, as well as men with a family history of someone diagnosed in a first-degree relative before the age of 65. So that brings back the age of initial screening to 40 years old. So, of course, we have to talk about the elephant in the room that you mentioned, the grade D recommendation, essentially the scarlet letter from the task force issued in 2012. And they really highlighted 2 points. Number one, the harms related to the treatment of screening detected cancer, as well as the harms related to screening and diagnostic procedures. So every action has a reaction, and we're beginning to see that. And this is recent data published in JAMA Oncology looking at the incidence of prostate cancer. And for the first time, we are detecting a precipitous decline, 18% in the diagnosis of prostate cancer. Now, this would be good if we were only talking about low-risk disease, but we're also seeing declines in the diagnosis of high-risk disease, which is really quite concerning. So what did the task force get right? And I think we do owe them a debt of gratitude to bringing these issues to our attention. Overdetection is a problem, and historically, rates of treatment were too high for patients with low-risk disease. It also brought to our attention the limitations of PSA as a biomarker for identifying significant cancer. And I think it also sort of reinvigorated the conversation regarding the potential harms of biopsy. But what are the problems with the statement? I think these are really widely recognized by people who are interested in cancer, especially prostate cancer. First and foremost, that early detection is critical to the treatment of aggressive disease. And if we abandon screening wholesale, the impact could be really quite dramatic. In a CISNET modeling study, they estimated that complete reversal of screening would result in 36,000 to 57,000 preventable deaths by 2025. I also think there are significant flaws in the way that the task force interpreted the data from the screening trials. They heavily weighed the PLCO trial. I didn't really have time to get into the issues with that, but the PLCO trial was really not a trial of screening versus no screening. In fact, in the patients who were randomized to no screening in the PLCO trial, 90% of them were screened. So it's really a trial of ad hoc screening versus organized screening. And they really de-emphasized the ERSPC study. There's also some concern of the way that they overestimated the harms of biopsy as well as the risk of death from treatment. There's a statement in there as well mentioning our inability to distinguish high-risk tumors from low-risk tumors, which we take issue with, as well as a complete avoidance of the issue of high-risk groups and how they should be handled. Particularly, I think the issue of low-risk disease and our inability to distinguish good from bad is quite problematic. And in fact, there is really a robust body of literature supporting the safety, efficacy of active surveillance for low-grade tumors. These are tumors that harbor low-grade features, and we can very, very reliably predict patients who have low-grade disease. A recent publication looked at national utilization is up over 40%, and our utilization rate is much higher at Yale. Lastly, we are moving well beyond PSA with much better biomarkers that are in our armamentarium that have far better specificity for detecting aggressive prostate cancer. I'm highlighting one that we're actively involved in using, and that is the Prostate Health Index, which significantly outperforms PSA in predicting high-risk prostate cancer, the prostate cancer that's worth finding without detecting low-risk prostate cancer. So I'll stop there and just sort of make some conclusions here. I think first, a very high level of evidence supports early detection practices for reducing morbidity and mortality. We do wholly recognize the harms and controversies associated with PSA screening, though. And our institutional guidelines seek to maximize the benefit of screening by identifying individuals most at risk and really prioritize patient values through shared decision-making. I think we can also minimize the harms through clinical excellence, which we're committed to, and we're taking a leadership role at Yale to refine the science of prostate cancer screening. And lastly, and perhaps most importantly, we owe a debt of gratitude to you for being here, because this is a tremendous opportunity for engagement really across the aisle and among disciplines in the cause of our patients. So thank you very much.